Hi, and welcome back to the third lecture in the Intervention, Development and Evaluation module. Before we get into the meat of this week's topic, I just wanted to revisit a couple of questions that came about from last week's lecture that Danielle had fed back. First one was around more information about how COM-B acts as a system. Second is what the difference is between optimism, the theoretical domains of optimism, and the theoretical domains of beliefs about consequences differ. And thirdly, where behavioural regulation best fits with COM-B. So, first question, COM-B as a system. So, as an example here, just to recap on COM-B, we need the capability, the opportunity and the motivation to perform any behaviour. Now within that as a system, capability and opportunity can directly influence how motivated we are. Our skills, our knowledge to perform a behaviour in terms of capability can directly impact on how motivated we are, and our opportunities in terms of our time, our resources, the social opportunities afforded by what other people do and what others want us to do can increase our motivation directly. But motivation can only influence capability and opportunity acting through behaviour. So let's take the example of cycling. So if I increase my opportunity to cycle, for example, by having a bike, that might increase my motivation to go cycling. No behaviour required. By having a bike, my motivation might increase. Similarly, by having the capability, if I have the skills to ride a bike, that might also directly impact my motivation to ride. I might be more motivated to cycle than I would be if I didn't have the skills to ride a bike. Okay. The only way that my motivation can change opportunity is through behaviour. Motivation in and of itself, having the motivation in and of itself will not change your skills. Just by being motivated will not change your skills, and just by being motivated will not change your opportunities. That has to happen through some kind of course of action. So an example of how I might be very motivated to cycle, but the only way that that will change my opportunity, for example, is by doing something, by performing some behaviour, such as riding a bike. Or if I had a bike, my motivation might change my opportunity by planning the time and affording greater time or opportunity to ride my bike. The only way motivation can change capability is again through doing something. So by practicing cycling to increase my skills, increasing my psychological capability, or maybe increasing my physical capability by improving my balance on a bike. So that's just one example of how COM-B acts as a system. The second question was about what the difference was between optimism and beliefs about consequences, and whether they were one and the same. And just to draw a distinction between the two of them, when we're talking about optimism, and I've put up the definition of the theoretical domains and the constructs that it plays to around optimism, pessimism, unrealistic optimism, identity. So and for beliefs about consequences is beliefs, outcome expectancies, characteristics of outcome expectancies, anticipated regret or consequence. To put it more simply, optimism is how hopeful one is that a particular behaviour or goal will be performed. Beliefs about consequences are what will happen if that goal is performed, and those consequences can be positive or negative. So the optimism is, to what extent am I hopeful that something will happen? Beliefs about consequences. What are my belief structures around what will happen if something happens, if I perform the behaviour, if a group performs the behaviour? The third question was around how behavioural regulation fits into COM-B. So behavioural regulation is one of the domains of the TDF, anything aimed at managing or changing objectively observed or measured effects. So this is things around self-monitoring, breaking habit, action planning. So essentially, these are psychological skills, what we're talking about here, the ability to regulate one's behaviour, the ability to take notice of what one is doing, monitor, and to act on the feedback on that behaviour. So based on what I have monitored, that, say, on an individual level, what I'm doing, what do I then plan to do in the future that may change to meet my goal? Those are counted as psychological skills, and that is why behavioural regulation is mapped to psychological capability on the TDF. So, learning objectives for this lecture are to be able to develop metrics based on the COM-B to identify influences on behaviour, to be able to identify validated TDF questionnaires. There are a number out there in the literature, and just a signpost to those. And then a couple of examples of how COM-B or the TDF have been used to collect data to either identify influences on behaviours or mechanisms of action. So the structure of this lecture will be looking at how we've developed measures based on COM-B. It's yet to be validated. The COM-B questionnaire that appears in the guide is not a validated measure. It's just intended as a way of exploring capability, opportunity and motivation, and we'll look at the different ways that we've done that in one health and one non-health example, and the methods that we used for that, and also signpost to a couple of validated measures of the theory domains framework that elaborate on COM-B, as we saw in the last session. We'll then look a little bit at data collection methods and signpost to where you might find more information about that. And then two examples, one about ways in which these tools have been applied to existing interventions to work out how they're having their effect or how their intended effects are, what their intended effects are. And secondly, to an application to design interventions. And this will be something that will carry through to the next couple of lectures. That particular example, I know that Daniel has fed back that there's a need to have a consistent example. So one end-to-end example from Carol Sinnott's paper on designing an intervention to manage medication in multimorbidity. We'll look at that going from end to end in terms of how they used the behaviour change wheel to design that intervention. So, starting off, developing measures based on COM-B. As I said in the book, we give examples just of how one might explore capability, opportunity and motivation. And one example, and I think this is in your reading, is looking at understanding variation in adenoma detection rates. So this was a group of healthcare providers that work for Kaiser Permanente in Northern California. And they came to us saying that they knew that there was huge variation in terms of the number of polyps that were detected in colonoscopies. So colonoscopies, routine exams that people would go to every 3 years on average to screen for colorectal cancer. And it's a complex screening process in terms of probe being inserted, looking for polyps that may turn into adenomas. And on average, of 100 men screened, one would expect to see polyps in about adenomas in about 25%, and in women about 20%. But there was huge variation. A few physicians would see much more of those, and or spot more of them, and some physicians would spot far fewer. So what was the reason for this variation? So we constructed a simple focus group topic guide. We chose focus groups for pragmatic reasons, and we'll talk a bit more about methods of data collection later on, but just to focus on the development for now. We were guided by COM-B and anything in the peer review literature that was going to guide us. So firstly, when it came to thinking about capability and physicians' capability to perform a colonoscopy, we wanted to know, well, did they actually know what they were supposed to be looking for or removing? And as you'll see written up in the paper, that there was a big disagreement. It was assumed that everyone knew what they were looking for, and there was huge disagreement about what was removed, whether it was something that was just 2 millimetres or 5 millimetres. So that in itself was a first finding. Do they remember what to do, or do they forget? Physical capability. This was certainly relevant in this situation because it's very difficult to manoeuvre the scope. You have to manipulate it, move it round the colon. That's quite a sort of complex area to negotiate. And so it's quite difficult. And when people are doing a number of exams, they become physically fatigued, wrist starts to ache. And so that's a factor to consider. In terms of opportunity, did they have the right management support? Did they have the right equipment, time, enough staff to do that? And certainly when it came to equipment, there were variations in the quality of equipment that people had, the amount of time that people had. Certainly in the US healthcare system, people were prompted to carry out as many exams as they could in as short a time possible. And in relation to not just the number of staff that were available, but actually keeping staff after hours. They didn't want to be the ones that were keeping people when the staff were sort of drumming their fingers, which was almost verbatim what somebody said. And also any contrary views or opinions of others about their decision to remove a particular polyp or whether something was a polyp. In terms of motivation, do they think that's part of their job to do it? Did they have confidence in their ability to perform this procedure? Do they think that it doesn't actually matter because people are always going to come for follow-up screening? Had they decided that they weren't going to particularly look for anything and go through the motions? Were there any conflicting priorities, other things that they might want to achieve rather than that? Or was there anything enforcing them to, or reinforcing them to act in that particular way, such as benefits or penalties? And in terms of automatic motivation, were there any uncomfortable feelings? Certainly the patients who were partly sedated for the procedure would sometimes cry out in pain when they were manipulated on the table while they were being examined. So that was one of the factors as well. So we used that in focus group situations to explore what the barriers and facilitators were. And if you look at the paper, you can see the full write-up of those that were key. And certainly in the next lecture, what we're going to look at is when you elicit a number of influences on behaviour, how do you then decide which ones are key? And we'll work through that on the next section. Another example, not from the health arena, but closer to home, was looking at recycling behaviours at UCL. So UCL Environmental Sustainability Team had implemented a new system of recycling in one building, and we evaluated that compared to a control building, similar one, but where there wasn't any sort of or minimal contamination of traffic using both of them, to look at, was this effective in terms of people were putting waste in the waste bins, putting recycling in the recycling bins. And when it transpired that there wasn't any difference, what they wanted to know, well, what do we need to change to get people to be using this new system? So again, this time it was one-to-one interviews. It wasn't feasible because of the nature of recruitment to do focus groups. So we did one-to-one, face-to-face or telephone interviews. And again, structured questions around COM-B. So psychological capability. Do you know what needs to be put in each bin? Have you ever used a bin, but you've not been sure what to put in it? Are you actually able to take the items you intend to recycle to the bin? Physically, are there too many in one shot? Because people didn't have recycling bins in their office, it required them to go down corridors. So, opportunity. When you needed one, how often did you have access to it? And socially, do you think that your colleagues are people who recycle? Do you think that you recycle more often or less often when people are around you, or when you're alone, or is it the same? And motivation, in terms of identity, do you think of yourself as someone who's a committed recycler? Do you think that this is something that you should take personal responsibility for? Beliefs about consequences, what impact do you think it has? Do you think it has benefits? Are there any harms? Is it something that you intend to do? Are you in the habit of doing? And this series of questions elicited interesting approaches certainly in terms of the beliefs about consequences, because people were saying things like, well, yes, I know it's important to recycle, but you look at all of the energy that's taken up in terms of recycling plants and sorting things out, because they have sorters there. So how important is it for me to put things in the right bin in the first place? And also questions around whether it was actually cost effective to cycle. So we were able to surface all of these issues that we might not have been able to do had we just brainstormed these questions. So again, what these tools are doing is forcing us to think broadly about what is influencing behaviour and probe those. And certainly, just in my experience of using COM-B, going back to that question about whether people knew what to remove during colonoscopies. So these were physicians with X number of years of training and experience. And I was almost moved away from asking about, do you know what to remove? Because it's kind of an obvious question. And I said, well, if we're not going to ask that, are we assuming that there's a clinical guideline out there that's telling people what to remove? Oh no, fine. We ended up asking it. And as I said earlier, one person, oh yes, it's anything over 5 millimeters and over, we'll remove that. And then someone looked at them and said, 5 millimeters? No, I'm 3 millimeters. And all of a sudden, this major issue that one would have assumed everyone knew what to do suddenly became something that was rather salient in terms of our intervention to, firstly, to explain why there was such variation, but also in terms of signposting to an intervention that's going to reduce that variation and bring those to the norm, to the average and above, became much more relevant. So 2 examples of ways in which we have exploded capability, opportunity and motivation. Now, in terms of how we develop those measures, similar for both. So in the first instance, we were guided by the models, by either TDF or COM-B, and in the example of colonoscopy, we were rather time poor, so we used COM-B as a screening tool. So is there anything that you need to know, knowledge or skills? Do you know what you're looking for? And if when we got the answer, there were more things, as you'll see from how the TDF impacts onto COM-B, that there are a number of different domains that you can then explore. So we were guided in the first instance by, well, let's make sure that we include questions on all of these components. We then looked at evidence from the peer review literature and thought, are there any areas that we know, not just within, for example, beliefs about consequences, but are there any particular beliefs about consequences that we need to be looking at? And we were able to pull more in from the peer review literature. Now, it might be you don't have time to do that if you're trying to understand influences on a particular behaviour, or you don't have access to it. Another option is stakeholder input. So to draft that questionnaire according to COM-B and then put that out to a number of stakeholders and say, are we asking the right questions here? Are there other things that we need to ask? This is as comprehensive as we're being guided to be, but are there specific things within that that we might not have pulled out from the evidence base that we need to be asking about? So that was to broadly get the content, and then to shape that, we also piloted it doing think aloud studies. So getting people in and talking through the questions and talking through their understanding of what each question was asking them, and making sure that they were understandable and hitting the mark in terms of what we wanted to elicit, and getting response from people, and also enabled us to either revise what we were doing, or even weed out potentially redundant items, as the stakeholder input part of the process was as well. So that was how we went about developing those. So that's from a kind of non-validation sense. I want to just highlight a couple of measures here. So we have from the theory domains framework, which precedes COM-B by some 6 years or so. 3 examples from the literature of validated TDF measures. So the first one was Natalie Taylor and her colleagues at Bradford, looking at a measure of physical activity. So just, I won't go through all of those here, but just to show you an example of how one might explore various domains of the TDF. So when we're thinking about, for example, emotion, when it comes to physical activity, whether we want to, if we want to understand the extent to which people's emotions influence whether they engage in physical activity. So daily life is too stressful, I have too many negative emotions, which prevents me from doing physical activity. When I think about doing physical activity, I start to worry. In terms of beliefs about consequences, if I do physical activity, it will benefit me in the short term. If I do it, it will benefit me in the long term. I think physical activity will change my life for the better. All positively framed questions in that particular aspect, but they're not necessarily all positively framed. The other thing to point out here is that this was based on the first iteration of the theory domains framework. So you will see that there is a domain called motivation and goals, which in the second validated version that I presented to you last week is intention and goals. So there are some differences in those domains. So what was 11 domains now becomes 14. But just to give you some examples again of how researchers have elaborated on those domains, and there's a number of studies out there to the tune of 500 or so that have used TDF. Some of them have used validated measures. Some of them have just taken the TDF and adapted it to their particular context. There is no right or wrong way. These researchers did that because they had funding and an aim to do so. That does not mean that just because you are not going to validate the questionnaire that you should not be using it, but that this is potentially a good starting point, and you know the statistical underpinnings of this particular measure. Similarly, Nat Taylor and colleagues produced another for patient safety measures. So in this particular questionnaire, they were looking at patient safety in relation to a particular behaviour. So when they were asking the questions, and this is crucial of COM-B and of using TDF, is that to get the most accurate understanding of the behaviour that you're trying to change, is that if you can link it to a specific behaviour, the more specific, the more accurate your understanding. So in this situation, they were looking at all the things that might affect you being able to ensure that patients are only sent for an X-ray if it is impossible to obtain aspirate or the pH reading is above 5.5. So linked to a particular behaviour, and then this was in the context of a questionnaire, giving a 5-point Likert scale from strongly agree to strongly disagree. The final question I want to draw your attention to regarding TDF is looking in general about implementing guidelines. So this is looking at in general, sort of implementation behaviour. So this is looking in the healthcare arena, but again shows you examples of how they have expanded on knowledge, how they have expanded on skills, social professional role and identity. So for example, delivering this, following the guidelines is part of my work. It's part of my job to deliver following the guidelines. It's my responsibility, so on and so forth. And what they've also shown here is the sources that have informed how they've come up with those items. So some of those have been guided by the framework and following kind of knowledge, skills, social professional role and identity, beliefs about consequences, capabilities, so on and so forth. But some of it is also drawing on the literature. What have others found in terms of the salience of these domains and how we might explore them? So another source of data in terms of how one might compile a questionnaire. So we've talked about different ways of exploring COM-B in different questions one might ask, looked at some validated measures of TDF, data collection methods. A number of options are available. They are available depending on one's aim, on one's resources. So you can gather this data same is true for both. You can gather the data by questionnaire, as we've seen. If I can just scroll back, one can have a simple kind of like a strongly agree to strongly disagree scale, or free text responses. So questionnaires, largely useful. This is general kind of data research method stuff. Questionnaires more helpful when you're wanting to gather more data and largely quantitative data. You might choose interviews or focus groups. They're more resource intensive in terms of gathering the data and synthesizing and interpreting the data, but arguably one gets much richer data in terms of eliciting themes within various constructs. So when we're talking about themes, so what particular aspects of beliefs about the consequences? Is this consequences, so for example, in terms of screening for colonoscopy, is it beliefs about consequences in terms of ramifications for the patient, in terms of it being more painful? Is it ramifications in terms of the health professional, in terms of time consuming, or concerns about litigation, which was one of them that came up. So going into greater detail in terms of either interviews or focus groups, and again that is dependent on resources, we'll get that richer data. Document analysis is another. One can review protocols and track back through what was the intended mechanism of action. We'll see an example of that shortly. One can observe practice, and again something coming up in terms of how that was used. Or those largely used, certainly questionnaires, interviews, focus groups, document analysis used in the research setting. If one is time poor, simply having a structured discussion that either is centred around the COM-B or particular domains of the TDF, just to be as comprehensive as one can, given the resources one has. Again, these are simply lenses through which to view behaviour, so you apply them according to the resources that you have. And when we're thinking about data collection, just a couple of considerations. So who are we collecting data from when we are say in the process of designing an intervention, and we want to look at what the barriers and facilitators are? Arguably, we don't just want to interview those or survey those targeted for change. We want to triangulate with other perspectives. We're not great at reflecting on our own practice. We are to a degree, but that is strengthened by bringing in perspectives from others that are working with us that can speak to what we do. Secondly, what are the sources that we use? Some of that might be directly from the people whose behaviour we're trying to change, or those allied to that, those perspectives we might triangulate with the perspectives of those whose behaviours we're trying to change, but also documentary evidence, observation. Now, how many people should you interview? Well, if you have limited resources, it's as many as you can. Generally, which is not a helpful response, but if we take it as the example given in research, if you are looking at a particular group, say you want to understand the experience of rail staff working on the railways, you might be looking at train drivers, you might be looking at conductors, you might be looking at staff working on the lines, or mechanics working on the lines, or those operating signals, or those making announcements. Now, ideally, what you should aim for is around 10 per group to have enough rich data look at whether there are any themes that differentiate according to a common behaviour. So it's about 10 per group in the research setting, but again, it's whatever one can manage. And again, we're talking about applying this to, even if it's a 5-minute discussion round table. So there's that on the spectrum. And there is a lot more information on developing materials, on sampling strategy, and certainly what we'll be looking at in the next lecture, which is how one interprets data. The guide to using the theory domains framework that we published earlier this year, essentially the same rules apply with COM-B. The same methods exactly can be applied using COM-B or any theoretical measure. So let's look at a couple of examples now. First one, identifying mechanisms of action in an existing intervention. So how have COM-B or TDF been used to identify how an intervention might be having its mechanism of action? And then looking at intervention development. So, an example application. So this is looking at the implementation of UK sepsis guidelines. So sepsis can start as an infection and then develop into a systemic inflammatory response, then go to develop to sepsis, and then septic shock and multiple organ failure. Main cause of death from infection worldwide, mortality rate of 40%, and in the UK, 64,000 hospital deaths a year. There is a clinical care bundle called the Sepsis 6. 6 behaviours, but when one really unpacks it, there's a lot more behaviours, but summarised into 6 behaviours that, if implemented within an hour, halves mortality. So this includes measuring blood lactate and taking blood cultures, giving fluids, giving antibiotics, giving high flow oxygen, and measuring urine output. So those 6 behaviours. So the setting is a North London hospital, and they had put together a package to implement this care bundle in a number of wards. So the implementation package included training and education about Sepsis 6, audit and feedback on whether it was being conducted, some changes to the ward, and staff support. Now, they had set the goal of 95% compliance with this care bundle. And in 3.5 years, and in the case of the A&E department, many iterations of this guideline had not yet been able to achieve target compliance. So, in collaboration with before the Centre for Behaviour Change, with the Health Psychology Research Group at UCL, so a project led by Susan Mickey, the first step was to find out, well, what are they actually delivering? So to find out what the techniques they were using, and being able to retrofit that on what the intended mechanism of action was. So some of you may be aware of the behaviour change techniques taxonomy. This is something that you will be going into much more detail in a couple of lectures' time, led by Fabi Lorencato, who's the research lead at Centre for Behaviour Change. But the behaviour change techniques taxonomy is a way of standardising the language of behaviour change. So these are the irreducible components within an intervention that are designed to bring about change. And they applied this list of behaviour change techniques. And they had three sources of data. The first was to actually observe what people were doing. The second was to examine documentary analysis. To examine documents, so protocols describing what should be done in terms of implementing Sepsis 6. And the third were interviews with health professionals. And that identified that how they were trying to implement Sepsis 6 was through 19 behaviour change techniques. And what they then did was use COM-B and the theoretical domains framework to fit what those techniques were intended to change. So in using a particular technique, how was that changing either capability, opportunity and motivation, or in greater detail, was it changing if it was changing reflective motivation? Was it changing people's intentions or their beliefs about their capabilities or consequences or so on? So just a signpost to the paper. So this is Siri Steinmo's paper published in 2016. There are a couple of papers that came at this. First was documenting what the content of the implementation package was, and the second was looking at, based on their interviews, what changes needed to be made to that intervention that implementation intervention to support implementation of Sepsis 6. So just as an example, they observed that so group introductory education and training sessions delivered to staff in groups, and one of the aspects of that was a discussion about the severity of sepsis and how susceptible patients were to sepsis. Now that translates into the behaviour change technique information about health consequences. So if a patient is diagnosed with sepsis, this is what is likely to happen, this is how severe it is, and this is also how susceptible people are to that. Now that track back was performed largely the function of educating people, providing knowledge that they didn't have. The mechanisms of action is that one is trying to change psychological capability, if one looks at it through COM-B or through the TDF, changing knowledge. Another aspect of the intervention that they observed was the story of a young patient who died from sepsis. So again, same technique but delivered very differently in terms of information about health consequences. Now this was not about providing information that the staff already had, but about changing how they felt about implementing Sepsis 6. So this was not education, this was persuading people, and we'll talk more in a couple of lectures' time about intervention functions, but just to touch on that now. So the purpose of this was to persuade people, and that by persuading people how the intended mechanism of action worked was to change reflective motivation in terms of valuing doing it, certainly automatic motivation in terms of changing people's drive states about this and emotions about performing that particular behaviour. And again, if we look through the lens of TDF, it's beliefs about the consequences and one's emotions. So we go from story of a young patient who died from sepsis, staff being told that, that's targeting reflective and automatic motivation and beliefs about consequences and emotions. So one example of how one can use these tools to describe how an intervention might be having its effect, its mechanisms of action, not just the functions it performs to have that mechanism of action. A second example of how COM-B in particular has been used to design an intervention, and I know that as we mentioned earlier, Danielle has asked that we provide a sort of continuous example throughout these lectures. So we're going to take a little bit of a step back in terms of thinking about the problem, identifying the behaviour, and then moving through to where we are. But hopefully that will help. So this is looking at managing medication in people with multimorbidity. So multimorbidity essentially is when one has two or more conditions. So they're aware that there was a problem here. So their first stage, if we go back to what's defined in the steps that we set out in the Behaviour Change Wheel Guide, defining the problem in behavioural terms. So they knew that there was a problem. What data did they draw on to define the problem? Well, firstly, they looked at the peer review literature, they looked at systematic reviews, they looked at qualitative studies, and they also conducted interviews with GPs. So what was the problem in primary care? And essentially, there was suboptimal management of medication in multimorbidity. In who? In GPs, where? In primary care. Selecting the target behaviour. How did they go about this? Well, they looked at all of the modifiable behaviours that they'd identified in the literature and from their interviews with GPs. And to give an example here, so reviewing patients' medication regularly was a potential that would promote more optimal management of medication in people with multimorbidity, using practice protocols for prescribing or collaborative decision making with the patient. And then they rated each of those in terms of, well, what's the impact on managing medication in this group? If we manage to change them, what's the likelihood we can change them? And are there any positive or negative spillover effects if we change each of these? And just to give you a summary here, so reviewing patients' medication regularly, judged to have a large impact on medication, judged likely to be changed based on what GPs were telling them, and it could provide improvements in other prescribing behaviours. Using practice protocols, again, if you can get it changed, possibly a large impact on medication, unlikely to be developed due to and implemented because of cost and staffing pressures to come up with new practice protocols, but it may have a positive spillover effect to other medication management. Collaborative decision making with the patient, judged that it might have an impact on medication management, but the focus would need to be on GP communication skills, which was not the focus of this particular research group's work. So again, a pragmatic decision there in terms of the scope of their research, and but judged to have a positive spillover effect to other shared decision making. So reviewing patients' medication regularly was chosen as the target behaviour for people to improve, for GPs to improve management of patient medication. So the next step was specifying the target behaviour. So who, GPs, what active, purposeful medication review instead of the passive maintaining the status quo. When? During the appointment with the patient. Where? In surgery. How often? Regularly. With whom? With patients with multimorbidity. And then they needed to identify what needs to change. And this again came out of a review of the literature, so document analysis and applying the COM-B lens to that, and also interviews with GPs. So if they are going to engage in active medication review, what needs to change in terms of their capabilities, their opportunities, and their motivations? And in terms of their capabilities, They identified that psychological capability needed to change because GPs weren't certain which meds were most effective in the presence of other conditions. So if you're going to be changing medication, what are the interactions with other particular medications? In terms of opportunity, they were certainly concerned about harming the doctor-patient communication relationship, in terms of a patient that may have been on medication for a long time and all of a sudden you're suggesting that they might not need to be on it because you identified there's a need for them not to be on it, but might there be some sort of resistance and potential disengagement from that. And also the lack of time to go through reviewing the medication and all of the interactions if one is proposing any changes to one or more of those medications. And then finally, motivation. GPs were in the habit of just automatically printing off prescriptions. Reviewing wasn't particularly routine, and the perception that there are more important things to do, there are greater priorities than reviewing medication. So going through this process, the review team were able to, through interviewing GPs, looking at what the literature was saying, were able to identify a problem, identify a number of behaviours that were relevant to that problem, apply a criteria of impact, likelihood of change and spillover to identify an optimal behaviour, and then apply the COM-B model to identify if we want GPs to be actively reviewing medication, what are the things that we need to change in terms of capability, opportunity and motivation. So that's one example there in terms of how COM-B has been used in the former stages of intervention development. And in the next lecture, we're going to be looking at what, from the data that one collects when going out and asking these questions in terms of qualitative and quantitative data, how one then interprets that and prioritises what might be target for change, so one can continue along this process of being as systematic and comprehensive as one can be in a very messy reality. And look forward to hearing your questions also. Thank you.